There is a phrase in Australian medicine that does an enormous amount of work. 2 words: informed consent. And in Australia, it has two different operating meanings. One meaning carries legal and regulatory safeguards, and the other borrows from this phrase while thinning out those safeguards. When a hospital uses that phrase, when a regulator uses it, when a court uses it, when a parent reads it on a clinic's website, everyone reads it in the same way. It signals a doctor has assessed, weighed the evidence, explained the alternatives, disclosed material risks, and confirmed the patient understood enough to make a voluntary decision. That is the meaning the law in this country attaches to those 2 words. It is a meaning the Australian Commission on Safety, Quality and Healthcare attaches to them. It is a meaning the High Court attached to them in Rogers versus Whittaker in 1992. And it is a meaning that has been quietly hollowed out inside one corner of Australian medicine: gender-affirming care. While the phrase itself has been kept in place, informed consent, that is what I want to talk about today. Same 2 words, 2 different processes, one reassuring label. Let me start with a legal regulatory standard because everything else turns on it. In Australian healthcare, the definition of informed consent is set out by the Australian Commission on Safety and Quality in Healthcare, ACSQHC. The Commission writes the National Safety and Quality Health Service standards that every hospital and clinic in the country is meant to operate under. Their definitions has 4 elements. A patient decision must be voluntary. It must follow accurate information about alternative options available. It must include disclosure of the benefits and material risks. And the patient must have adequate knowledge and understanding of what they are agreeing to. So it includes voluntary, alternatives, material risks, adequate understanding, 4 elements, all 4 required. Sitting underneath the definition is 1992 High Court case, Rogers versus Whittaker. That case sets the legal duty to warn. A doctor must disclose any risk a reasonable person in the patient's position would likely attach significance to. Failure to do that is a breach of duty of care. It is the basis on which doctors have been successfully sued in this country for the last 30 years. So when a clinic in Australia tells a patient or a parent that informed consent has been obtained, this is a standard they are invoking. It is a standard every regulator, every court, every journalist, every parent reads that assertion against. There is no second specification. There is only this one. AusPath is the Australian Professional Association for Trans Health. It is a peak body whose standards of care guide private gender clinics across the country. Its current document is the Australian Standards of Care for Informed Consent Gender-Affirming Hormone Therapy, version 2, 2025. Latest update was actually in April 2026. On page 12, and I ask you to download it and read it for yourself so it gets through. On page 12, that document quotes the ACSQHC definition I just read out. It quotes it verbatim. Voluntary decision, alternative options, benefits and material risks, adequate knowledge and understanding. 4 paragraphs later, still on page 12, the same document describes what it calls the informed consent model for gender-affirming care. And here's what it says. Under this model, the threshold for initiation of, and it's referring to gender-affirming hormone therapy, is simply informed consent. It, quote, it rejects the idea that a medical professional must validate an individual's gender experience. As GPs, our role is to facilitate and respect those choices. On page 13, the document goes further. It recommends that primary care practitioners offer hormone therapy and other interventions based on the individual's self-identified needs, and I quote, rather than rigid diagnostic criteria, unquote. Listen to what has happened on a single page of this document. At the top of page 12, the ACSQHC definition. Inside that definition, 4 required elements, including alternatives, including adequate understanding. At the bottom of the page, a model in which the threshold for treatment is the consent itself. The clinician's role is facilitative, not evaluative. Diagnostic criteria are described as rigid, and across the whole 76 pages of this document, no alternative to hormone therapy is presented. The terms exploratory psychotherapy, watchful waiting, and no treatment do not appear. The Royal Children's Hospital Pediatric Guideline takes the same approach for under 18s. TransHub, ACON's clinician portal, puts it more plainly still. It says medical gender affirmation does not require a diagnosis because being trans is not a form of sickness. It says informed consent allows patients to make choices around their bodies and enables patient-led care. Notice the difference. Same phrase, same regulatory authority invoked, different meanings applied, different processes underneath. In our recent compliance work, AWW, we mapped this side by side. 6 aspects of informed consent under the standard medical model against the same 6 aspects as they appear in clinic materials and OSPATH aligned documents. I'll walk you through it. Okay, number 1, diagnosis. So the standard model has formal clinical assessment. A clinician collects the history, considers different diagnoses, arrives at a formulation, and discuss it with a patient, even if the patient disagrees with the conclusion. On the gender-affirming care model side, there's no formal diagnosis required for non-complex cases. The threshold is a patient's self-identified need. The outcome of the assessment is, in practice, predetermined. Evidence quality. On the standard medical model side, a doctor must disclose the strength of the available evidence, including uncertainties and limitations. The gender-affirming model side, limited disclosure of evidence quality. OSPATH's 2025 document was published more than 12 months after the CAS interim report review, and the University of York systematic reviews became publicly available. Those reviews found the evidence base for pediatric gender medicine to be of low or very low certainty. OSPATH lists 143 references or citations, and none of them mention the CAS review, University of York systematic reviews. Excuse me. Risk and benefits. On the standard medical model side, full disclosure of material risks based on best available evidence. On the gender-affirming care model side, risks like infertility, bone density loss, surgical complications, and the persistence of mental health issues after treatment are minimized, deferred, or framed as uncertainties research will eventually resolve. On alternatives, a standard model side, a doctor must discuss all reasonable alternatives, including non-medical management and doing nothing. On the gender-affirming model side, the alternatives, exploratory therapy, watchful waiting, mental health support, are either not presented or are reframed as a form of gatekeeping or conversion therapy. I kid you not. Children in capacity or minors in capacity. On the standard medical model side, heightened duties for minors, best interests of the child, formal capacity assessment, parental involvement, multidisciplinary input. On the gender-affirming model side, the informed consent model is applied to under 18s with limited public disclosure of age-specific protocols. Developmental immaturity is acknowledged for the body, but treated as not impacting a young person's ability to know anything, let alone their innermost gender. Ongoing monitoring. So once you've actually had a treatment, you monitor it to see if it was successful or not. That's what it means. On the standard model side, continuous evaluation of outcomes for the individual and ongoing evaluation of the approach as a model of care. On the gender-affirming model, limited published long-term outcome data on desistance, detransition, or systematic adverse event reporting. So there's 6 rows. And there's 6 departures from the regulatory standard the document on page 12 cites as its own authority. The 2-word phrase, informed consent, is doing all the work of legitimizing those 6 departures because the phrase carries the moral and legal weight of Rogers versus Whitaker's of the Charter of Human of healthcare rights of the Commission standards. Every regulator, every parent hears the phrase and assumes the standard. If you want to know what this model looks like when it runs all the way to its endpoint, the United Kingdom has just given us a documented case. Last Friday, NHS England and NHS Sussex published the independent patient safety investigation into a private clinic in Brighton called Wellbeing. The investigators concluded that the care at Wellbeing, and I quote, fell far short of what could be considered safe or appropriate, unquote. Children and young people have been prescribed puberty blockers and cross-sex hormones by practitioners who, in the words of the NHS England's regional medical director, were, quote, neither qualified nor commissioned to deliver, unquote, that care. The investigation found that gender incongruence was never considered in the records as a phenomenon that might resolve with age, which, by the way, it generally does. It found that young people's emerging sexuality and sexual orientation were not explored. It found repeated, inaccurate, and misleading claims to children that the fertility impact of gender medication was completely reversible. Transgender Trend, the UK advocacy organisation, summarised it in one sentence. Wellbeing Clinic did not practice healthcare. They practiced gender-affirming care. The reckless disregard for children's health and safety is a feature, not a bug, of the gender-affirming care model. I'm going to make that into a meme. The investigation report does not need that framing to be devastating. The findings stand on their own. No diagnostic process, no discussion of alternatives, no proper informed consent, misleading information about fertility, practitioners operating outside their scope of practice, children at risk of harm. Every one of these findings maps to a row in the table I just walked you through. The well-being failures are not a deviation from the gender-affirming model. They are the gender-affirming model fully implemented. When safeguards are removed, these are the predictable failure points. I'm not saying well-being proof of every Australian gender clinic. It is, however, a documented safety case showing why the missing safeguards matter. And I am saying that all those missing safeguards are what we are seeing in the audits that we are doing. The argument I suppose I'm making is a restorationist one. It's not a radical one. Nothing new needs to be invented to address what AWW's audits have documented, what the Cass Review documented, what the Wellbeing investigation has now documented. The diagnostic process exists. The standard for disclosure of material risk exists. The duty to discuss alternatives exists. The heightened safeguards for children exist. They already govern oncology, surgery, pediatrics, eating disorders, identity disturbance in adolescents, and every other corner of Australian medicine. The standard medical model is not insufficient for gender-distressed patients. It is the standard medicine ordinarily applied to distress. What our audits ask, what the Cass Review asked, what the Wellbeing investigators concluded is that gender-affirming care be brought back to the same framework that governs everything else. One doorway leads to ordinary, high-quality medical care. The other leads to a predetermined pathway that bypasses safeguards and minimizes material risk, all under the same reassuring label of informed consent. Words matter. Standards save lives. The two-word phrase that has been doing the work of legitimizing the second pathway needs to mean, in gender medicine, exactly what it means everywhere else in Australian medicine. That's not too much to ask. It's what every patient and every parent already has a right to know. Everyone. Sorry for getting worked up. The audits and submissions are published at aww.org.au. I'm still putting them all up. It takes a lot of work. This work is unpaid, it's evidence by evidence, and it's slow because it has to be detailed and double-checked and triple-checked, etc. But the questions we are asking are the questions every Australian parent has a right to ask about any treatment offered to their child or to anybody. That's it. Thank you. Bye.